This is Dr. Alicia Relaz again, and I'm a psychiatrist teaching at UCSF, as well as developing continuing education programs for Alliant International University. Today we have another fascinating study. This one is looking at Lexapro for hot flashes. Now obviously Lexapro wasn't intended for menopausal symptoms, so we are talking about off-label uses. However, it's very important that something for these hot flashes is developed. Up to 75% of women during the menopausal or perimenopausal period will have hot flashes, and these can be very devastating to sleep and to functioning in general. So in this study, Lexapro, the antidepressant, which is an SSRI, was compared to placebo treatment and was found to be significantly more effective in reducing hot flashes. Now just to let you know, there have been some other studies looking at Paxil and Prozac and Effexor that have had similar results. So it looks like antidepressants can help with these hot flashes. Now why would that be? Well, there's a part of our brain called the hypothalamus that helps regulate heat or temperature in general. So if it seems to feel that we're too hot, the vessels will dilate and will sweat and have redness in order to release some of that heat. The hypothalamus functions pretty normally with a steady level of estrogen. When estrogen starts fluctuating, this ability to regulate our heat is thrown off. Now why is this? Well, what estrogen does is it monitors the amount of neurotransmitters, such as serotonin and norepinephrine, that are projected onto the hypothalamus and allow the hypothalamus to function. So when estrogen starts fluctuating, the serotonin and norepinephrine going to the hypothalamus starts fluctuating, and then our heat regulation is off, giving us these hot flashes. So it makes sense that giving someone an SSRI, which will help to regulate and keep the serotonin level at a steady amount, would then make up for some of this fluctuation of estrogen. So the hypothalamus isn't so dependent on estrogen to keep the serotonin levels steady. Now they're kept steady by a medication, and the hot flashes will decrease. Now, of course, being in mental health, we have to wonder, how does this figure in with depression? Is there any relation? Well, there is, to a certain extent, but it's more of an association than any sort of cause back and forth. So we have seen that women who have hot flashes are about 5 times more likely to have depression during the perimenopausal period. And it's not a causation, like I said, so it's not that they have hot flashes and that causes them to be depressed. But rather, if we know that estrogen is causing those serotonin and norepinephrine levels to fluctuate, not only is that going to give us hot flashes, but those fluctuating levels of neurochemicals are going to give us the symptoms of depression. So someone who has one is likely to have the other, and the reason is the same, that those neurochemicals are not stable. So what this means is that when someone's having depression during the perimenopausal period, we might look at treatment a little bit different. And one of the things that I've noticed is that sometimes serotonin alone, so through an SSRI, might not be enough to treat that perimenopausal depression. The reason being is that norepinephrine is also dysregulated. So sometimes with depression during the perimenopausal period, if you want to use just an SSRI, you might need to use a little bit of hormone replacement therapy as well. Now, we have a lot of concern about hormone replacement therapy, as we know it can increase risk of strokes and breast and ovarian cancer in older women. So obviously this would be done in conjunction with a gynecologist who would look at the woman's other risk factors. But for depression, you might look at treating with an SSRI, and if that isn't effective on its own, adding in that hormone replacement therapy. Another way around this is to use something that affects both serotonin and norepinephrine, such as Effexor, a newer form of Effexor, which would be desvenlafaxine. So Effexor's venlafaxine, and there's Pristiq or desvenlafaxine. And duloxetine might also be tried. Again, these are not necessarily on-label uses for all of these medications, so you'd want to check into this and make sure it's right for your client. But it does provide a very fascinating look at yet another area where the brain and the body may be related, and how treating our mental health symptoms can also help treat physical health. So I look forward to the next fascinating study to share with you, and until then, this is Dr. Alicia Relaz signing off. Thank you.